This is Dr. Stone-Gale. This lesson that I'm going to talk about is on breaking bad news to patients. And unfortunately, it's one of the most difficult duties that you will have as a family nurse practitioner because it's just, an uncomfortable situation. Without having the proper understanding of what to do, the discomfort and the uncertainty associated with breaking bad news can really make you disengage emotionally from your patients. So, we're just going to do a very brief overview of the protocol that works very well to help deliver bad news to patients and to go over some of the those protocol steps. So, what is bad news? Well, bad news is really defined as any news that drastically and negatively alters the patient's view of his or her future. And, it can be associated with a terminal diagnosis. It can be associated with bad news such as, fetal demise or an abnormal ultrasound. It could be bad news about a cancer diagnosis. So there's many types of bad news that you can give a patient. How they respond to the bad news really is influenced by their psychosocial context. There may be just a simple diagnosis that comes at a bad time when they're maybe going through some difficulties in their marriage or difficulties in their home life or difficulties at their job. So that very simple bad news could turn into, be exacerbated because of other extraneous things that are going on in their life. When you care for, multiple members of a family, then the lines between the patient's needs and the patient's family's needs could really become blurred. Most of us have had a conference room full of family members that we've seen, such as when maybe we've worked in the hospital and we are giving bad news in an emergency room or in an ICU, when the conference room or the waiting room is full of members that are going to sit there and be told this bad news about the family. And sometimes we pull them aside in the hallway and talk about it, with the family members and as well as the patient. So it's very difficult sometimes for you to really say, how am I going to do this? What am I going to do? And so who is the person that really needs to break the bad news? Well, as I said, you are now in a different role. And your role, it has now changed from being the nurse to the nurse practitioner, to the primary care provider, to the one who is going to be breaking bad news to these patients. You really are need to have some type of a therapeutic relationship with the patient and identify how they're really going to react to this. So you are doing a different role now. So your breaking bad news is going to be something that that is going to kind of be distressful to you in your practice. And why is it so hard? Why do we have such a hard time breaking news to patients? Well, there are many reasons why. One of the common concerns is, how is it going to affect the patient? How is it going to affect the family? It's interesting because Hippocrates advised that concealing most things from the patient while you are attending to him and giving necessary orders with cheerfulness and with serenity, revealing nothing of the patient's future or the present condition. For many patients who have taken a turn for the worse by forecast of what is to come. So Hippocrates, many years ago, did not feel that it was appropriate to break bad news to patients. They wanted us to conceal these things from the patient. But in the past few decades, there's been some traditional paternalistic models of patient care that really have looked at empowerment of the patient as well as autonomy of the patient. And when looking at many different studies that are out there on patient preferences regarding, whether they want terminal illnesses disclosed to them, It's interesting because 50 to 90% of these patients wanted to know. And they want to know what their time is. They want to be able to get their affairs in order. They want to be able to spend time doing things that they've wanted to do. I think about the song that Tim McGraw wrote for his father when he was dying. The song Live Like You Were Dying. And when you listen to that song, it really hits home as to why some patients do want to know that they're not going to be here very long. So you have to really ascertain how they would like to have the bad news addressed. And you face the challenges of really individualizing the manner of breaking news and the content delivered according to what their desires are, what their needs are. And sometimes the family members will tell you that they don't want the patient to know, but that's not fair. You have to think about what the patient wants, not what the family wants. And we also as practitioners have our own issues about breaking bad news. It's an unpleasant task. We don't want to take any hope away from the patient. Um, we may be fearful of how the families are going to really react to this news, or how they're going to, what kind of emotional response they're going to have. And sometimes we're forced to deliver bad news without forewarning, and this is very uncomfortable also. So, learning general communication skills really does help you to break the bad news in a manner that is less uncomfortable, excuse me. And, one of the things that we do is we say, how should it be delivered? Well, it's going to be different for every situation on how it should be delivered, but it needs to be delivered in the most compassionate and effective methods that you can. There's a study by Rabo and McPhee where they talk about a practical and comprehensive model for synthesizing the bad news, and it's called the ABCDE. So you may read about that. It is a mnemonic that's used for breaking bad news to patients. So, being prepared in advance yourself, as well as, building a really good environment and communicating well and dealing with the patient and their family reactions, and then, validating their emotions. But the one that we're really going to focus on is the Spikes protocol. And the Spikes protocol is a 6-step protocol for delivering bad news to patients. And this is something that I think is very easy to think about. It's easy to follow, and it really kind of gives you a lot of good information. There are barriers to breaking bad news, and you know, despite these challenges, less than 10% of patients really practitioners really feel comfortable doing this. So this might help you a little bit to have some type of a strategy to give bad news to patients. This is a plan for determining their values, their wishes for participation in decision making, and a strategy for addressing their distress when the news is disclosed to them. This might also help to encourage patients to participate in some difficult treatment decisions that they may have to go by. So the 6-step strategy for breaking news is called Spikes. And we talk about step 1, it's setting up the interview. So you have to think about what you're going to say to the patient. You have to mentally prepare yourself. And you really need to be prepared as far as a lot of questions that are going to be asked in regards to the diagnosis that you're going to give. So you need to do your research. You need to have read some literature. You need to read up on what you're telling them because of all these questions they're going to have. So as the messenger of the bad news, you need to expect to have some type of negative feeling, and you may feel very frustrated, and you may feel responsible for what you're saying to the patient. So it's helpful to be reminded that although bad news may be very sad for the patient, It also is important, as I said earlier, to allow them to plan for their future. Do they want to do anything? Do they not want to do anything? Do they want to go on a trip? Do they want to go spend time with all their family members? Do they want to spend all their money? Whatever, doesn't matter. They need to think about what they're going to do. So sometimes that physical setting causes the interviews about sensitive topics to flounder. And unless there is some semblance of privacy and the setting is conducive to undistracted and focused discussion, then sometimes those goals of the interview might not be met. So you need to be arranging for some type of privacy, not do it when there's other people in the room, such as visitors. If it's family members, that's one thing. If it's coworkers, if it's neighbors, then that's another thing. You really don't want them in the room. So you want to make sure that the patient has privacy. You want to make sure they have family members that are present. So, because many times when you give this information to a patient, that's all they hear is what you said, and then you've lost them. They're only thinking that word cancer or that word terminal. They're not really comprehending anything else you say. So it's important to have other family members there to kind of go through listening to what you're talking about so they can inform the family or the patient afterwards. You want to be able to sit down, not stand over the patient and be, act like you're at a higher level of them, but you want to sit down and relax. And this is also a sign that you're not going to really rush through what you're going to tell them. You are there to sit there, tell them, explain to them, talk to them. And this really, when you sit, you're trying not to have barriers between you and the patient. Make some type of connection with them. So you want to, maintain eye contact. And sometimes that's very uncomfortable, but you want to maintain eye contact. And this kind of establishes some type of rapport with the patient. Sometimes if you touch them on the arm or you hold their hand, this gives them a sense of caring on your part, and it makes them feel good. You want to also manage any time constraints and interruptions, and put your phone away, put your phone on silent so you're not interrupted. Step 2, assessing the patient's perception. 2 and 3 kind of go together. The perception and the invitation. Excuse me. But step 2 and 3 of spikes are points in the interview where you implement the before you tell, you ask. So before you discuss the medical findings, you usually get some open-ended questions going, trying to create a reasonably accurate picture of how they perceive the medical situation, what it is, and whether it's serious or not. So, for example, you could ask them, why do you think we did the MRI? And what is your feeling in regards to the medical situation that you might have? What do you think is going on? And let the patient kind of see if he'll open up or he or she'll open up to you. So you can get a lot of information from the patient this way, and some of it's misinformation, and that you need to really correct and clarify with the patient. And you also accomplish the important task of determining if they are in denial, if they have wishful thinking, unrealistic expectations of treatment. And then step 3, where you obtain the patient's invitation. Some patients express a desire for full information. They want to know about their diagnosis. They want to know the prognosis. They want to know the details, every little detail, and others don't. So when you hear them express, the desire for information, it really lessens the anxiety on you, and you can kind of openly talk. You've kind of validated that psychologically they're open to what you're going to tell them, and their coping mechanisms are there, and they may be more likely to understand you. If the illness is more severe, then you may have more difficulty. But discussing the information disclosure at the time of ordering the test also can give you some information as to what you're going to plan on your next discussion with the patient. Because if you're suspecting, for an example, if somebody comes in and they have a lump in their neck and it's not sore and you're suspecting could they have a lymphoma, and you send that patient out for an MRI or a CAT scan, anticipating that you're pretty sure it's going to come back, then you've got time to think about how you're going to plan your next discussion with the patient. So you can say things like, how would you like me, to give you the information? Do you want me to give it all to you now? Do you want me to call you on the phone? Would you let's bring you back in, and kind of feel them out that way. If they don't want to know the details, then maybe talking to a family member is the best thing that you can do. Your step 4 is giving knowledge and information to the patient. If you give them the upfront and say to them that you have, there's bad news coming their way, it's less shocking for the patient. So what I mean by that is saying to the patient, unfortunately, I got your results back and I do have some bad news for you, or I'm sorry to tell you that this is occurring. It kind of upfront, you've mentioned those words, bad news. So you've kind of prepared them a little bit. And giving medical facts may be, improved by just some simple guidelines. First, start at their level of comprehension. Think about where their level is, where their vocabulary is, and try not to use real technical words. Use non-technical words. Instead of saying something has metastasized, you can say something has spread. Instead of saying we did a biopsy, you could say we took a sample of your tissue. And then you don't want to be blunt. The last thing you want to do is walk in the room and say, I have your test results and you have cancer. And unless you get treatment, you're going to die. That is not the way you want to approach your patient. The patient's going to be angry, they're going to be isolated, and they're going to blame you for giving them this bad news. So you want to give them stuff in small chunks. You want to check periodically to make sure that they're understanding it. And then when the prognosis is poor, you don't want to say to them, there's nothing more that we can do for you. You're going to die. You want to give them some type of hope, or some type of idea that, there's therapeutic goals that we can help you through this with pain medication to control your symptoms so you have some quality of life. So there's ways to say things without getting real blunt. And then the 5th thing is addressing their emotions with some empathic responses. This is probably one of the most difficult and challenging things when you're breaking bad news to a patient, because their reactions are so varied. They're either going to be angry, they're going to cry, they may scream, they may hit the table, they may just be in disbelief, they may shut down completely. So when they get bad news, their emotional reaction is often an expression of shock, or they become isolated in grief. And so you can really give them some support to, by some empathic responses. So look at some of their facial expressions. Observe them for any emotion. So are they tearful? Are they sad? Are they silent? Are they shocked? Identify that emotion, that they have, and use open-ended questions to see if you can find out what they're thinking and what they're feeling. And then this is usually connected to bad news. And if you're not sure, ask the patient to identify the reason for that emotion. Maybe the emotion isn't just the bad news you gave them. Maybe they're thinking of a marriage that's coming up, or some important event, and that this has just really struck a chord with. And then give them some time to talk about their feelings, express their feelings, let them know, that you've connected with them on an emotional level, and that, you're understanding what they're going through. So you can say, I'm really sorry, but your x-ray showed that you have a large tumor in your lung. Unfortunately, the tumor has grown somewhat. And, I know this is not what you wanted to hear. I wish I had better news for you. And then touch them, hold their hand, something like that. Don't give bad news like this over the telephone. Um, and then until you can really feel the emotion, it's difficult to go on and discuss other issues. This may not be the time to discuss the treatment plan. This may be the time to say, let me let you digest this. Let me let you process what I talked to you about. Let me let you talk to your family what I talked to you about. And then we'll come back and we'll discuss what some of the options are that we can do to help you. And let it kind of lay at that. And then set up a time to come back or bring them back into your office. And then you're doing some type of strategy, some type of summary with them. So, if they've got a clear plan for the future, they're less likely to feel anxious, they're less likely to feel uncertain. And, we talked about this just a minute ago in regards to letting them think things through and bringing them back and talking about what some of the decisions are, seeing who they want to be involved in the decision-making process. Do they want their husband? Do they want their mother? Do they want their sister, their brother? Who do they want in there? And then sometimes we're very uncomfortable when you have to discuss the prognosis and the treatment options. But, these may be done down the road, and you may get a clear understanding of how the patient feels once you can start expressing to them what their treatment options are. The difficult discussions can be greatly facilitated by using some strategies. You may already have some idea of the seriousness of their illness and of the limitations for treatment, but you don't want to bring up the outcomes at this point. So you want to let them kind of digest everything. They may see cure as a solution to several different problems that are significant for them. This may include, that they can't take care of their family. They're going to lose their job. How am I going to do this? I have a sick wife at home. I have a sick husband at home. I have a sick child at home. There's many different things. And so, they're going to be expressing these fears and these concerns regarding their condition and how they're going to work through this themselves. And then, setting these goals, reassuring them. So all of this is part of that strategy and summarizing their care. So this is unfortunately a part of your practice and part of what you're going to have to do. Breaking bad news affects the patient, not just the patient's psychophysiologically during the process of disclosure, but it also affects the healthcare provider psychologically. And it's very difficult sometimes to get into these situations and to really understand what the patient is going through. So I think that if you look at the Spikes protocol and you do review it, and there's some videos that I would like you to watch in the module that will give you an idea of what a good discussion is with a patient and what a bad discussion is with a patient.